Hello. Hello. So we start. Yes. Very good afternoon to all my dear students. Welcome to DAMS recall session Pharmacology by Dr. Thiru. To start, I think May 2025 aims questions are very interesting and very simple. Most of the questions, say 99.9% are question from our workbook or from DVT or from LRR. So I think if you studied everything comfortably, you can enjoy it and you can go to very good. I mean, most of the questions, diet question only. We start. The first question I'm going to start. I just segregated all the question in system wise. The first system, general pharmacology. As you all know, for INICET, general pharmacology, the most important area. They ask you four questions from this chapter, from this system. To start, the first question: which of the following factor is most critical in determining oral loading dose? Okay, asking what is the important factor necessary for calculating loading dose. I think it's a multiple response question. You know, bioavailability and most importantly, volume of distribution and target plasma concentration. See, the formula for loading dose is equal to total dose, that is target plasma concentration multiplied by volume of distribution. The most important factor that for intravenous route main BD, whereas for oral loading dose main you have to include bioavailability also. So formula bioavailability equal to target plasma concentration multiplied by BD divided by bioavailability. That means this and this. So answer A, C, D is the multiple response question. It is the answer for the first question. Okay, Sairam and my dear other friends, if you are following, if you have any doubts, you please ask doubts also. If I have some wrong option, you mention the wrong options also. I will rectify. Okay, I think most of them options I made correct only. Anyway, we'll go for discussion. Question number two. Which of following statement is about phase 1 metabolism of xenobiotic is correct? It's a very straight question, man. When I say phase 1 drug reaction or metabolism, it includes oxidation, reduction, hydrolysis, cyclization, and decyclization. So it includes oxidation, reduction, hydrolysis. So answer for the question is option number A. It is a single response question. Answer is option number A. Whereas look at the other option. That's addition of polar conjugates. See, conjugate, when you say conjugate, that become phase 2 reaction. All the conjugation reaction like glucuronide conjugation, glutathione conjugation, glycine conjugation, sulfate conjugation, including acetylation, methylation, all are phase 2 reaction. Coming to C, detoxification in lipid bilayer. No, detoxification of drug usually occur in the liver, not within the lipid bilayer. And make more hydrophilic. So phase 1 is not going to make hydrophilic. And that too, when become hydrophilic, that's become water soluble, that is ready for excretion. So when a drug become hydrophilic, it will ready for excretion, not enter into cell. So the right answer for the question, option number A, that is phase 1 main oxidation, reduction, hydrolysis, cyclization, and decyclization. Next question. Very simple question. That no need to study and all. Straight to answer from the question itself. Look here. Matching type of question. They ask about tolerance, acute tolerance, cross tolerance, reverse tolerance. Look here. Cross tolerance. What do you mean? Cross tolerance mean decreasing in response with the other drug. For example, decreasing in response with the other drug of the same class. So 1 mean 3. For example, look here. If a patient is tolerant to alcohol, mean he may be tolerant to benzodiazepines. So, both the benzodiazepine and alcohol having same action on GABA A receptor. So, if they're tolerant to alcohol, they be tolerant to benzodiazepine also. That's called cross tolerance. Cross tolerance. Okay. Whereas, what do you mean by acute tolerance? When you say acute tolerance, that is uh, rapidly the developing tolerance, that is decreasing in response of drug after continuous administration. So B mean go for 2. So 1 mean A mean go for 3, B mean go for 2. What is acute? For example, if I give repeated dose of ephedrine for allergy or nasal congestion, they within 2 days or 3 days the response will decrease due to depletion or storage of norepinephrine. So rapid development of tolerance called acute tolerance, or very rapid mean we can go one thing called tachyphylaxis, but he is asking about acute. Okay, so when you give repeatedly some drugs, for example, if you give repeatedly nitrate, they develop intolerance. Repeated ephedrine, develop intolerance. The action become decreases, the way efficacy become decreases. So they need high dose to get the same action. What is reverse or reverse opposite? Tolerance mean decrease response. Reverse mean opposite. That means there's an increasing in response. They called reverse. So C mean answer one. For example, I have something called amphetamine, a psychoactive drug. This will you repeatedly, they may be aggravating the response. They cause more psychiatric problem, but we don't use this nowadays because of causing a lot of psychiatric problem, so loss of appetite, all this thing. Anyway, reverse tolerance, opposite to tolerance. There's an increasing in response called reverse due to sensitization, like that. So this is a straight question. Fourth question. I think this may be for some students difficult. To matching, if you know one or two option, you can match others easily. So matching question. They given insulin, veterinary drug, morphine, and vaccine, and they asked something with matching. Which is schedule? Which schedule? For example, I go for right answer. Insulin are available only after getting prescription from the doctor. Prescribed drug. So when you get the drug only after prescription, mean they call schedule H. We won't think of OTC, over the counter drug. That is without doctor prescription, we can get some drug. They call over the counter drug. Whereas schedule H mean only with the prescription we can able to get. So insulin is a schedule H schedule. And veterinary drugs, they cover drugs specifically. Veterinary practice mean they call is that shall listen. Morphine, a narcotic causing addiction. So the narcotic drug, psychotropic drugs are comes under X category, like your teratogen, thalidomide, X category risk. Similarly, there is risk category here. Schedule X mean narcotic drugs comes under Schedule X, and vaccine. The biological substance or comes under your category G. So the answer for the question, insulin mean go for Schedule H, veterinary drugs mean go for Schedule Z, morphine mean go for Schedule X, and vaccine mean go for Schedule G. So that finishes the 4 questions from general pharmacology. So again repeating, for INICET, general pharmacology most important. Even for NEET paper, those who are going for NEET also, please focus on general pharmacology, very important topic. Next, most important topic, ANS, but this time only 1 or 2 questions only coming from this system. We'll discuss. Which of following best explain the renoproductive effect of phenol-dopam? This and all we repeatedly discuss in our regular class notes. Okay, so phenol-dopam. When they ask in this question, without saying the option, you should come with answer. Phenol-dopam, a synthetic catecholamine, selectively acting on D1 in renal blood vessel, increases renal blood flow. thereby increasing kidney blood supply, thereby improve kidney function. So, short-acting drug useful for treatment of hypertensive emergency with renal impairment. The same dialogue we discussed when we discussing in class notes. Now, look at the option. Alpha 1 blocker, no. Alpha 1 blocker means prazosin, terazosin, doxosin, tamsulosin, cellulose, like that. It is not this. AC beta, no. They end with the prill, captapil, listenapil. Selective D1 agonism, yes, that is the answer. So, phenoldiazepam, a selective D1 agonist acting on renal blood vessel, improve renal blood flow, thereby improve kidney function. So, very good drug for treatment of hypertensive emergency with renal impairment. Option D, dopamine. D2 agonism, no. D2 receptors are mainly involved in CNS. For example, most of the antipsychotic drugs are having D2 blocking property, whereas anti-Parkinson drug having D2 agonism property. So D2 mean mainly CNS, so not for this. Anyway, the right answer for this question, option number C. Okay. Yes, Pradip, even though initial step phase one mean best in initial even on initial step of the phase one, there's a adding of oxygen molecule or removal of oxygen molecule or adding of hydrogen molecule. So either oxidation or reduction or hydrolysis, they are the phase one reaction. Other options totally not relevant to phase one reaction, Dr. Pradip, right? So in this question asking telling even on initial step of phase 1 reaction, this only happening. All these are not for phase 1 reaction, Dr. Reddy sir. Okay. So now concentrate on my next question. Look, which of following is the first line vasopressor for the management of septic shock? See, in a regular class notes, we making notes on shock. Shock and different treatment. Where I discuss this point. When we say septic shock, the guideline says for treatment of septic shock, the best first line vasopressor always go for norepinephrine. It is the first line vasopressor for treatment of septic shock. If this option is not given, the second option can be ephedrine. Ephedrine is second line drug, but it's a first line drug mean only one answer, single response question, answer go for norepinephrine. Second line can be ephedrine. Whereas look at the other option, dopamine. Dopamine, a wonderful inotropic drug, so useful for treatment of cardiogenic shock with oliguria, not for septic shock. In this case, they may worsen the arrhythmia. It has D1 action, beta 1 action, alpha 1 action that may worsen the arrhythmia. It's a wonderful drug for shock with oliguria. And then vasopressin. Vasopressin, a wonderful vasopressor, but it is usually given adjuvant. It's given as an adjuvant to norepinephrine. It is not used as a monotherapy. It is not the replacement of norepinephrine. It can be an adjuvant to norepinephrine for treating septic shock. So the best single answer mean go for option C, norepinephrine. Coming to very easy question. Reversal of vecronium after cardiac surgery done by what? See, usually in our regular class we discuss vecronium in immediately mind says reversal by Sogamadex. Vecronium, rocronium, reversal immediately by Sogamadex. But in this May 2025, they are not mentioned about Sogamadex. So what the answer? See, normally for reversal of curare drug like vecronium, rocronium, pancronium, all the curare drug we used to go for anticholinesterase. For example, neostigmine. Wonderful. So answer is option number B. Neostigmine, a cholinesterase enzyme inhibitor, going to accumulating acetylcholine, thereby improving muscle contraction. So for reversal of non-depolarizing SMR, we can go for news treatment. But one doubt, if it's a multiple response question main, we can add this also. Usually, when they give news treatment, it's going to accumulate acetylcholine that will have muscarinic and nicotinic action. But I want only nicotinic action. So I can combine with the anticholinergic like atropine or glycopyrrolate. This can be, but they ask you only single response question. The best answer go for option B, newest treatment. Whereas crocodile baclofen, baclofen a GABA B agonist. It is a centrally acting SMR. It's a SMR, skeletal muscle laxant. Already muscle laxant. How can you use this? So not useful. It is mainly useful for muscle spasm or controlling craving of alcoholism, like that. Baclofen useful for hiccup. And coming to dandrolin, dandrolin a directly acting. It's a directly acting SMR. When I say directly, I mean acting on ryanodine receptor, inhibiting calcium efflux from sarcoplasm, thereby controlling muscle contraction. It's a wonderful drug of choice for malignant hyperthermia. Malignant hyperthermia. So it is also muscle laxant. So these two are muscle laxant. They can be useful for this case. The best answer go for newest treatment. Okay, next. That's all about A in this question. Into serious. In this May 2025, usually in AIMS exam, serious not that much they concentrating. Now they ask one question. Look here. Type 2 diabetes patient having hypertension presenting with the heart failure symptom, tachycardia, systolic BP 90, ejection fraction 60 percentage. What is the best treatment? First, Dr. Pradeep Sairam, Tulsi Yadav. Can you please answer whether the same options are given or some other options are given? Somebody post only see this option. See, the option are loop diuretic with the SGLT blocker, digoxin, ivabradine, dopamine infusion. If this is the answer, how to go to this? Patient having hypertension with the diabetes, having heart failure, systolic BP 90 only. So hypotensive status with the heart failure symptom. So here I want to relieve the symptom. So what the best answer? Look here. Digoxin, a wonderful drug for heart failure, especially with the atrial fibrillation. So nowadays, use of digoxin not that much, only for heart failure. So I don't want to go for this. So leave this, okay? And Ivabrine, a funny current sodium channel blocker, it is useful for treatment of heart failure with reduced ejection fraction. Here this EF is 60%. So I don't want to go for this. So B and C are ruled out. The question is either A or D. That's the question. Look here. Look at option A. Loop directing. You know, a wonderful first line drug for acute heart failure because they're rapidly going to relieve the symptom like breathlessness, all these things. Problem is they given AGL2 blocker. AGLT2 blockers are wonderful drug useful for preventing disease modification. Okay, but only one doubt I have: when they give loop diuretic, it may cause further fluid loss, may cause hypotension. Already BP is very low. When you go for this, they may cause further hypotension, so risk will be aggravated. Okay, so what the guideline says, better go for dopamine infusion because heart failure with the hypotensive shock, go for IV dopamine infusion because it has D1 action, beta 1 action, alpha 1 action. This will improve cardiac output. It will give symptom relief. It will increase BP. That's my opinion. Anyway, if controversy exists, I will ready to accept the controversy. But the guideline says better go for dopamine infusion. But some people are telling answer A also because loop diuretic is a first line drug for acute shock. So I'm giving for this. But they say it's a dopamine infusion, the best answer. So this will controversy. Anyway, answer I think D. Okay. Now, that's about serious. And coming to blood shift, they are now in May 2025, they very much focus on blood. In the blood shift, usually they ask about anticoagulant, antiplatelet, thrombolytic agent, toxicity, and all. But this time, for a change, they ask about cholesterol. See, every year in INICET, there's a new drug in cholesterol chapter asking repeatedly. This year, not new drug, but new point. The question, true statement about pembidic acid. This question done when we have INICET predictors, at the time I discussed this question going to come like this. So please go and verify. Okay. So true statement about with the preserved ejection. Okay, okay. That's why ejection. Come on. Pineapple pizza. Pineapple pizza. That's why. See, when I said preserved, this is preserved. Ejection fraction. It means preserved ejection fraction. That's why I don't everybody not useful. It is only for reduced ejection fraction, not for preserved. Okay. So here go for this one. Dopamine going to improve cardiac output. Okay. Yes. Now look at this. Regarding true statement about pembidic acid is what? Come on. Pembidic acid, a cholesterol lowering drug, true statement. I think it's a multiple response question. Look at the options. It's a non-competitive inhibitor of ATP citrate. It's a true statement. Point one. It's a non-competitive ATP citrate lyase. Actually, the ATP citrate lyase is the initial enzyme involved in synthesis of cholesterol. So, pembidic acid inhibiting initial step of cholesterol synthesis. So, point one. By inhibiting ATP citrate lyase, it inhibiting cholesterol synthesis. When it inhibit cholesterol synthesis, causes upregulation of LDL receptor on the liver cells, thereby peripheral LDL are taken by hepatocytes, thereby ultimately by drug going to lower plasma LDL level. Point one. Point number two, used as an adjuvant to maximum tolerable dose of statin. Yes, yes, good. Look here. Statins are wonderful drug for lowering cholesterol, but the study shows when add pembidic acid statin, they came with the answer. The pembidic acid able to lower LDL cholesterol by 18 to 20 percentage when added with the statin. So, when you want to achieve very good control of LDL, even after using statin maximum dose, what is the best mean? Add the pemmidic acid. When you add pemmidic acid, the further reduction of LDL. So, in case of atherosclerotic cardiovascular disease, or in case of heterozygous familial hypercholesterolemia, in this case, even after using maximum dose of statin, still the cholesterol you want to reduce mean add the pemmidic acid. Some of the told actually there's a reference there's a from cholesterol lowering journal. In the journal only I mentioned the answers they're inhibiting on allosteric site, not the same site. So it's a non-competitive. Educate me. There's evidence from journal. It's a non-competitive one. Okay. And it's a dicarboxylic acid. Yes, it's a structurally it's a dicarboxylic acid derivative. So it is true statement. It is true statement. It is true statement. Inhibit attenuation? No, no. This is done by statin. See, pemmidic acid going to cause upstreaming of HMG coagulase. They're not going to inhibit. Only statins are inhibiting HMG coagulase. So the right answer for the question option number A, B and C. Okay. A, B, C. Right. So peptidic acids A, B, C. Except D. That's all. Coming to next question. Erythropoietin is useful in which of the following type of anemia? I think it's a very simple physiology, pharmacology, medicine question. See, when you say erythropoietin, we have something called erythropoietin preparation like epoietin alpha, erythropoietin, like this. The erythropoietin, one, it's a single response question. The best answer go for anemia due to CKD. Erythropoietin, a wonderful drug for treatment of anemia due to CKD. Only one answer. Okay. For aplastic anemia, we go for bone marrow transplantation, or we going to go multiple. Not this one. For neutropenia, we go for iron, folic acid, B12. Not this one. Myelofibrosis. Here, fibrosis, there's no chance for production by using erythropoietin. So, single answer, go for answer option C. Now, CNS, come on. The most important system for AIMS exam CNS. I repeatedly in CNS focus that to epilepsy and psychiatry, two most important area for INICET. The same thing happened. So look at this. In the CNS, first question. An 8-year-old girl was taking 800 mg of carbamazepine daily and was prescribed 1 gram of erythromycin for 14 days. Within 2 days, she began to develop the difficulty in balancing and ataxia. What could be the cause for her symptom? Very simple question. Patient is on carbamazepine, one of the anti-epileptic drug, comes under sodium blocker, and he was also taking erythromycin, a macrolide antibiotic. Look here, erythromycin, a macrolide, and it is a powerful microsomal enzyme inhibitor. It's a microsomal enzyme inhibitor. Now, when I give carbamazepine, erythromycin, they're developing difficulty in balancing ataxia. That shows signs and symptoms of carbamazepine toxicity. Here, she experiencing relapse. No, it is not relapse. It's a symptom of carbamazepine toxicity. Experience yes, yes. Answer option B. See, erythromycin inhibiting the metabolic degradation of carbamazepine. The big carbamazepine get accumulated and causing risk of toxicity. Science is option B. No, erythromycin toxicity. No, erythromycin toxicity will be causing G problem like diarrhea, sometimes causing reversible ototoxicity, sometimes calling cholestasis release. Okay, and experiencing hypersensitivity. No, no, hypersensitivity is different pattern. That is in some people in HLA. In some HLA people, they cause something allergy. Not this one. Okay, so answer is option B. Okay, next. Which of the following anti-epileptic drugs is most strongly associated with neurological defect in the fetus? This is under LKG question. Among the anti-epileptic, the most teratogenic will be valproate, and it's the one causing massive risk of neurological defect. So, among all, it's a single response question. The answer is valproic acid. Actually, one doubt. Carbamazepine also causing teratogenicity. It is also causing neural defect, but incidence wise, it is less. So, question the most strongly mean best answer go for valproic acid. Whereas the lamotrigine limitations are relatively safer drug for using epilepsy in pregnancy. So, best answer go for valproate. No. All of the following are clinical uses of MGSO4 except. I think single response question. Look at MGSO4. Actually, we in our class discussed this one of the miscellaneous anti-Arabic. At that time, we told extra point role in asthma, role in obstetrics, role in GAT, like that. So now they are asking role in CNS. Okay, all are clinical uses of MGSO4 except reduces incidence of plaster operation. Yes. Reduces incidence seizure. Yes. Very good. It's actually drug of choice. It's a drug of choice for eclampsia. A hypertensive pregnant lady at the time of labor developing seizure eclampsia. For that, the best anti-epileptic MGS4. It's a neuropathy. Yes. So true, true, true. Improve kidney blood flow? No, no, no. It is going to decreases kidney blood flow. That's why monitor for urine outputs, monitor for respiratory rates, monitoring for knee jerk, ankle jerk. So it is not going to improve kidney blood supply. In fact, going to decreases renal blood flow. So answer is option number D. I think state question. Now somebody asking, especially Sairam asking. Come on, Sairam, for your question. I'm going. Okay, look at the question. A 45-year-old woman with the depression is prescribed imipramine. She is also taking diphenhydramine for allergic rhinitis. Which of the following interaction can be observed? This is a question. Look at option. Increasing norepinephrine. Come on. Before going to option, let me discuss the same, some fundamental. Imipramine, one of the tricyclic antidepressant. And most of the tricyclic antidepressant common mechanism action is inhibiting reuptake of norepinephrine and serotonin. Okay. And most of the TCS having additionally some other action like they have anti-muscarinic action, that's anticholinergic, and alpha blocking action plus antihistaminic action also. These are common properties of majority. And imipramine is the one having very strong anti-muscarinic. This way it can be useful for treatment of nocturnal illness also. Now coming to diphenhydramine. Diphenhydramine, one of the first generation antihistamine. Now the question, most of the first generation antihistamine having additionally having anti-muscarinic, that's anti-cholinergic property also. Now, what is the interaction? Come on, Sairam, look at the answer. What is the interaction? Look here. Increasing norepinephrine, no, blocks, yes. This also blocks muscarinic. This also blocks muscarinic. So addictively blocking muscarinic causing more and more risk of dryness of mouth, more dryness of mouth, dryness of eye, and more of tachycardia, there's palpitation, constipation, and urine retention going to occur. This is what interactions I am. Why confusing? Okay. 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 Impermine reducing. Impermine is asking impermine blocking H1. Then how this acting? No, no, no. See, both are having antihistaminic property. That's all. Don't get confused. And diphenhydramine inhibit. No, this and the wrong. They don't have enzyme induction or enzyme inhibitor property. So no interaction. The best answer for this question go for option B. Because they asking when you give two drug having same property, addictively anticholinergic property causing more and more anticholinergic adverse effect like dryness of mouth. Sairam, diphenhydramine late on given or before given, that is not the matter. Okay, the matter is both of them having anti-muscarinic property. Both of them causes more and more anticholinergic adverse effect like dryness of mouth. That's wrong. Whether this first given, that is given, that's all. It is not Dell's phenomena like alpha blocker first given, then we give alpha again. What happened? If I give beta blocker and then if I give, that's not that question. The question is when both are muscarinic blocker, what is the problem? The problem is more and more muscarinic side effect. That's all the question. Okay. So don't say you understand the concept. Don't worry. Okay. Just try to understand the concept. Right. Now, which of following new psychoactive drug works as a rapid acting antidepressant? So there's one new drug asking. Some new, not new drug, new question. Okay. New and psychoactive drug useful rapidly having antidepressant property. Answer cannabis, bupropion, ketamine, methadone. The best answer go for ketamine. Come on. Ketamine, a psychoactive drug. Actually, you maybe studied in our CNS class. It's actually a drug for anesthesia, but it has NMDA blocking property and psychoactive drug having antidepressant property. Especially we have one drug called S-ketamine. S-ketamine, a ketamine derivative given as a nasal spray useful for treating depression. So question, ketamine having antidepressant property. Okay, so answer is what? This is have no antidepressant. It's SNRI sorry, ND, between ND, noradrenaline, dopamine, reactive occur, already existing one, not neutral, and this is one not. So the best has to go for ketamine. Next. Which of following agents are used in the treatment of acute mania? I think super easy question. Come on. In acute mania, to control the emotion, anxiety, tension, we can go for it's a multiple response question. The best chance to go for valproate, lithium, haloperidol. So answer for the question option number A, B, and C. Amitriptyline is a TCA. See, for treatment of acute mania in many cases, don't use any antidepressant. Antidepressant will worsen the problem. Okay, so look here. Valproate the most effective for acute mania, controlling mixed episodes. Okay, and have rapid answer also. So benefit is rapid benefit. Haloperidol actually antipsychotic. What they say for treatment of acute mania, we can usually go for atypical antipsychotic like olanzapine, risperidone, ariprazole. If not, we can go for typical. That to go for haloperidol because it is rapidly able to control agitation and manic episodes. So it is also useful for acute mania. Lithium. Lithium, a wonderful mood stabilizer, useful for effective for acute, but the onset of action takes about 7 to 10 days. That's why usually given for maintenance to prevent the fluctuation of mood, but it is also having effect in acute mania. So it's a multiple response question. Answer option A, B, and C. And remember, don't use antidepressant because antidepressant worsens mania. So in case of many cases, don't use antidepressants. Now, all of the following statements are correct except single response question. Go this. I think easy. Richa Kumari, how does NMD block hearing antidepressant? Actually, antidepressant different mechanism. Actually, we say norepinephrine, dopamine is the main mechanism, but there are some other new points. NMD blocking effect also have mood stabilizing property. That's okay. Usually, depression mean we concentrate on norepinephrine, dopamine, and serotonin. But remember, NMDA blocker also going to modify the neurotransmitter level, thereby having antidepressant property. That's a new point. That's why the question. Okay. Now, all of the following statements are correct except opioid withdrawal rarely fatal. Yeah, true statement. Actually, opioid withdrawal causes usually anxiety, tension, goose flesh, or diarrhea, mydriasis, but very rarely risk of fatal event happening. Buprenorphine can be useful for managing opioid withdrawal. Yes, normally for controlling withdrawal, we can go for methadone. If not, we can go for this. It's a partial mu agonist can be useful. So true statement. Flumazenil is useful for management of long-term management of alcohol dependence. No, no, no. So look here. Flumazenil, an antidote for benzodiazepine. It is not for managing alcohol dependence syndrome. So it's a false statement. Cannabis withdrawal may cause minimal withdrawal symptoms. Yes, they may cause agitation, exhilaration. Some withdrawal symptoms are there. So true statement. So the right answer for question go for option C. Flumazenil is not going to useful for this case. For this case, flumazenil go for mainly your benzodiazepine poisoning. Okay. Now coming to endo. Usually, last and all in endo, diabetes left and right asked. They focus on diabetes and osteoporosis. But this year, only one or two question. One question. Okay. Gonadotrophic hormone receptor antagonist useful for what? I think multiple response question. Gonadotrophin hormone. That is gonadotrophin releasing hormone receptor GnRH receptor antagonist useful for all except useful multiple. Can you please answer, Saram? My dear other friend, educate me. Again, nicknames are very fantastic. Your nicknames are very good. Okay, can you please answer what the answer you made for this? Right, this is a multiple response question. What the answer? See, GnRH receptor antagonist going to block the GnRH in the pituitary, thereby immediately suppresses release of FSLH, thereby having antagonistic property. This property useful for treatment of ovarian cyst. Yeah, if there's too much of FSH, they cause follicular stimulation causing PCOD. To control that, we can try this. And male with hypogotrofy, it's already having antagonistic, already suppresses FSH LH level. So it cannot be useful for treatment of hypogonadism. So it is not useful for this case. Controlled. Oh, yes. It is useful for in vitro fertilization. For example, we have something called ganirelix, cetrirelix. They are useful to prevent premature ovulation in case of in vitro fertilization. So useful for this also. Cancer prostate, yes, definitely. See, in cancer prostate, overaction of androgen. So to suppress the androgen, we can go for this. So true statement. So the right answer for the question, go for option number A, option C, option D. So A, C, D is the best answer for this question. Okay. Next. Antimicrobial. Here also only 2 to 3 questions only. First question. A 25-year-old sexually active man presented to STD clinic with a 5 days history of purulent urethral discharge. Gram strains of urethral soft source, intracellular gram-negative diplococci. The patient is allergic to penicillin. Which of the following is the most appropriate treatment for this case? Yeah, fantastic question. Can you please answer? Anybody? I'm waiting. Look here. They shows patient having purulent urethral discharge and the swab shows intracellular gram-negative diplococci. This helps giving diagnosis having Neisseria gonorrhea, gonococcal urethritis. For this case, surely drug of choice is ceftriaxone. Now look here. The options are ceftriaxone, amoxicillin, tetracycline, vancomycin. Look here. I cannot go for this because patient is allergic to penicillin. Next, Venco, never. Venco useful only for gram positive infection, not for gram negative. So rule out. So only option is A or C. Now, what the best answer? Yes, the best answer go for ceftriaxone. Okay, because currently the guidelines is the best drug of choice for gonorrhea go for ceftriaxone. That's the best because tetracyclines are developing a resistance against gonorrhea. We can't use, but only one doubt. They say when a patient is allergic to penicillin, he will be allergic to all. We call cross reaction. No, the only thing called cross reactivity. That is, if a patient is allergic to one penicillin, he will be allergic to all beta-lactam. Okay, one exception, we have something called aztreonum. Aztreonum, a monobacter has no cross reaction. Okay, but doubt is ceftriaxone also beta-lactam drug. How can you choose what this? The one part. This is even though this is a cross reaction, it is more with the first generation cephalosporin, not with the third. So go for option A, right answer. But only one thing: if I'm suspecting there is allergic to ceftriaxone, then I can think of going for tetra doxy. Doxy can be useful, but usually Neisseria will develop resistance against doxy. Or else I can go for astro. But before this, rule out there is sensitivity pattern. So normally for this case, the best can go for ceftriaxone. If not, we can go for astro or doxy. But in this case, better answer go for your ceftriaxone. Next, which is the most appropriate treatment for patient with complicated UTI present with the septic shock? Yeah, it's a complicated UTI with the septic shock. Options are amoxicillinic acid, nitrofurantoin, meropenem, ceftriaxone. Now the best answer, not allergic but resistant. Oh, not allergic. Oh my God. Yeah, yeah, yeah. Yeah, not allergic. Yeah. Okay, 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 okay. Then answer. Definitely answer option A. So not allergic, not resistant to, yeah, resistant to penicillin. That means the best is ceftriaxone. Ceftriaxone 50 20 IM single dose. Best. That's the best answer. Okay. So answer A. Good one. On the rocks. You are the rocks. Good. Fantastic. Now, what is the most appropriate treatment for patient with complicated UTI present with a septic shock? For this case, so complication with the septic shock means go for the most extended spectrum drug like meropenem. That's best. It's a carbohydrate derivative useful for complicated UTI and extensively drug resistant cases. Okay, so useful for coverage for ESBL producing organisms like E. coli, Klebsiella. So far, that's whereas others are not that much useful for this case. Anyway, nitrofurantoin useful only for uncomplicated UTI, not for complicated. Others can be tried. But best chance go for meropenem. Next, yeah, very simple question. Malarial clinical cure. I think multiple response question. The options are artemisinin, sulfadoxine, chloroquine, primaquine. Very simple. Look here. Clinical cure mean a drug acting on erythrocytic stage, going to control the symptom like fever, chills. Here, the most fastest acting drug is artemisinin. So useful. Sulfadoxine might be useful, but slow acting, and low efficacy. Useful. Chloroquine, yeah, useful. It is also fast acting, but for this, there should be sensitivity. Okay, and primaquine, it is acting only on exoerythrocyte. That means useful for radical cure, useful for radical cure for Vivax. Okay, not for clinical cure. So the A, B, C is the answer. Clinical cure means go for A, B, C. They acting on erythrocytic stage and controlling clinical symptom like fever, chills, like. Whereas Primark useful only for radical cure. You want to call tefanoquine, tefanoquine, and Primaquine acting on exocytic useful for this one. Okay, and then coming to immunology, very simple question, straight question. Now in May 2020, one good thing happened. There's no question on monoclonal antibody, no questions on tyrosine kinase blocker. So that first area was a no question. But this question is very simple regarding thalidomide. True statement or Dr. H.S. Kiyaski, peptidic acid is a non-competitive blocker doctor. Okay. Now, thalidomide. Yeah. It's a very simple question. Thalidomide, true statement, no? Multiple response question. It's a teratogen, yeah, true. Causing phocomelia, so-called seal limb. So, definitely all will know they're going to cause limb abnormality. Anti-metabolites with immunosuppressant. No, no, false. See, actually, it's an immunomodulator. It having immunomodulatory effects, anti-inflammatory effects, and anti-angiogenic. That is VGF for blocking property. It is not a anti-metabolic. Anti-metabolic mean purine, pyrimidine, or folic acid group or drug. Not this. So it is not, and role in refractive multiple. Yeah, where thalidomide, pomalidomide are useful for refractive multiple myeloma. Bortezomib, a proteasome blocker useful with the steroid. For this case, we also go for thalidomide for this case. And useful lepra, yeah, useful for erythema nodosum leprosum, a type 2 lepra reaction. So it is also used also. So the right answer is regarding true statement, go for A, C, and D. The true statement regarding thalidomide. Okay. All except so all except mean go for this. This not regarding thalidomide. All are true. All are So except when you say except, answer will be except mean answer B. Yeah, I'll make correction. Okay, good ma. Riya Sharkar. So all are true except answer is option B. It is not a anti-metabolites. It only immunomodulator. Okay. And then I think this May 2025 they given more important for dermatologists. Okay. Dermatology question. Okay. Actually, the two question is actually the pharmacology area, but more of dermatology. Okay. For example, look. Which of the following treatment are appropriate for scabies in infants? See, I think it's a multi. Come on, Dr. Ria Sharkar on the rocks. Can you please answer? It's a multiple response question or single response question, man? The question was multiple response or single response? See, the single response means the best answer go for permethrin. It's the first line treatment for scabies in infant older than 2 months. Okay, single response means it is the best answer. Safer drug, effective drug, well tolerated drug. Okay, whereas look at the option B. 10% quota. Multi mean go. One is answer A. Okay, one is answer A. It's a multiple response question. Okay, man. Okay, I don't. One is answer A. Next. 10% protometon. Yeah, we can use, but what they say, it is not preferred in infant because it's limited efficacy, also potential for skin irritation. So we'll hear just wait. Ivermectin, it is not a topical. They're asking which are following treatment. I think they ask a topical. I think they ask about topical. Okay, all right. Treatment topical. I think topical word is there or not? That in the question. Okay. Ivermectin, a oral drug, it's not topical and it's unsafe for less than 15 kg and unsafe for less than 5-year child. So it's definitely ruled out. Ruled out. And 20% benzoyl benzoate. It can be useful actually what they say. So too irritant, that too for baby and may cause chemical burns and avoid infant unless highly indicated. If you want to go for this, you give under supervision. So not available, not available. Okay, not available. Okay, okay. So this can be. So depending upon answer, come on. I think we can go for two answer mean go for A and D. If they given three answer mean go for A and then D and then go for B. So, in my opinion, best is go for A and D. Anyway, clarify with dermatologist. In my opinion, the two answer mean go for A and D. If they're asking three answer mean go for A, D, and B, but never go option C is not at all answer. Okay, right. One more question from skin. Topical side effects of steroid. Come on, steroid when given topically, what are the adverse effects? I think it's also multiple response question. Look at the option. Hypertrichosis, skin atrophy, blue-gray skin thinning, acne. Okay. This is also multiple response question. Whether they given two response or three response answer key, I don't know what key they given, but I'm going to explain now. Look at what they say. Topical steroid have more risk of causing skin atrophy. So definitely B will be one answer. Topical steroid causes inhibition of fibroblast function, thereby decreasing synthesis of collagen and gum substance that are essential for skin dermal synthesis. So chances of skin atrophy will be there. One point number two. There is chance of increasing sebum production and follicular obstruction. So chance of acne is there. So we see next. It may cause hair follicle toxicity, stimulate hair follicle, especially by causing, especially with occlusion on when you give occlusive topical occlusive therapy and when you give long-term therapy, risk of hypertrichosis. This also. So the best chance to go for BCA. Okay, and this is very least Blue green is one very, very least because of causing skin atrophy. There may be problem. So it can occur, but very, very, very least. So the best answer go for answer is B, C, A. That's the answer. That's from Dermatology. And the last question, one miscellaneous question came. See, I collected for the past 2 days 25 questions from your students like you people. And the last question, look here. Which of following drug causes cholestasis without causing portal inflammation? Come on, Abhiram, what your answer? Which of following drug causes cholestasis without causing portal inflammation? The best answer go for steroids. Look here, estrogen and anabolic steroids are reported to cause cholestatic jaundice. They will impair bile salt transport across caliculi, thereby causing cholestasis. But they don't cause portal inflammation. So the best answer go for option B. Option B. But the doubt is regarding option A. Amoxicillin chlorinic acid. This will cause cholestasis, but they cause portal inflammation. They're asking which is causing with main go for option B. Whereas amoxiclav has a risk of causing cholestatic jaundice, may cause portal inflammation also. Then coming to CND, isoniazid anti-TB drug causing hepatocellular damage, not bile problem. They're not going to cause cholestasis. Acetaminophen, a paracetamol. Paracetamol causes dose-dependent risk of liver damage, causes dose-dependent hepatocellular toxicity. They cause hepatotoxicity but not cholestasis. So the best chance to go for option B. In fact, you should know a drug that causes cholestasis without significant inflammation. Just like the causing only cholestasis main answer estrogen like oral contraceptive pill or anabolic steroids, IV erythromycin. They cause cholestasis without portal inflammation. Whereas which are drug causing cholestasis with portal inflammation? Mean go for amoxiclav, carbamazepine, azithromycin, 6-mercaptopurine, sulfonamide, antipsychotic like phenothiazine category, right? And some phenothiazine like chlorpromazine, even the rarely sweeting, they may cause cholestasis with portal inflammation. I think I collected all the 25 questions. If extra questions are there, main kindly post. I will update. Okay. I think this discussion is useful for you. Can you please tell your feedback, doctor? Those who attend the live session, can you please tell this session is useful? I think most of question, 99 percentage question are direct question. Less than 1% you think because one question have multiple chapters. Some dermatology questions maybe confusing you, but other than dermatology, most of the questions are straight question. Water question in pharmacology question straight from our for book and from LLR. And I think DBT is definitely is a very good all the thing. Okay, so may God bless you. All the very best for your bright future. May God bless you. Thank you for giving the great opportunity. So thanks a lot. Thanks a lot. All the success. Okay, waiting for you. God bless you. Thank you, doctor. Thank you. Yeah, some asking Richardson, alcohol causes dose. Yes, yes. Come on. Alcohol, Dr. Richard. Alcohol in low doses causes excitation. They cause disinhibition and cause euphoria. When you keep on giving increased dose, they cause CNS depression, causing drowsiness, sometimes causing respiratory failure. So, in low doses, alcohol having CNS stimulatory property because of disinhibition and cause euphoria. In high doses, causes CNS depression. Yes, ma'am. The dose reduction is there. Okay. So, all the best, doctor. If any doubts, can you please ask? Or if you have any extra question, kindly post in my Telegram channel or NEETPG official Telegram channel, or I think you may be having my WhatsApp number. You post it. Okay. Thanks a lot, doctor. Thanks a lot. Thank you. All the best.